you can divide the risk factors into local factors. I mean, and this is what we did when we tried to find sort of a scheme of this in our book. Local factors are, in our mind, then factors that really favor, the oral pathogens in one way or the other. And you will, of course, then have oral hygiene very high up. If the patient has a bad oral hygiene, it favors the oral pathogens, of course. If we, by some reason, have a foreign body, like if we are cementing the superstructure, we get cementum down in the pocket, this will also favor the presence of the oral pathogens there. Periodontal health, as we discussed before, if we have a lot of teeth in the mouth of these patients that are not healthy, they are infected, we know that the bacteria can transform from the teeth to the implants. Soft tissue conditions, of course, this may be one reason also for that could favor plaque accumulation. We have situations where we have frenula that attaches very high up. You have no keratinized gingiva and so forth, making it more difficult for the patient to clean, which favors the oral pathogens. The initial peri-implant pocket depth as well. I'm not saying that is wrong in any way. I'm just saying that if we place the implants very deep, it is more difficult to keep it clean. And this, if it gets infected, it's also more difficult for us to keep it clean, which favors the oral pathogens. If the transmucosal part is very rough, it's more easy for the bacteria to attach, and it's more difficult for the patient to remove them. And then finally the implant prosthesis connection. How is the prosthesis done? Is it really done in a way that the patient can clean the area? Then we have things that will affect the susceptibility of the host, and things that could affect the susceptibility of the host are things like previous presence of periodontal disease, and this may be linked to genetics of the patients. They are more prone to develop an inflammatory lesions, some of them. We have some acquired factors, although there are limited data available. It may be like that there are indications that maybe untreated diabetes patients are more susceptible. And we have some environmental factors like smoking, alcohol consumption, and things like that, that will maybe then increase the susceptibility of the host. So oral pathogens, a susceptible host, may lead to the presence of periimplantitis. This also from the study where we looked at the presence of periimplantitis, we looked at are there any factors that really are associated with peri-implant lesions? And we look for mucositis, and for mucositis we found that keratinized mucosa and plaque are the one on implant data, on the local implant, that could give a correlation to peri-implant mucositis. On the explanatory on the patient-based data, the only one that were on patient-based is smoking. So smoking was explanatory to that. And in a recent, not so recent now, time flies, it's in 2009, a review by Lisa Mayfield, she found that things like poor oral hygiene, you see it has a very high odds ratio, 14.3. A history of periodontitis. She found that in 10 out of 11 studies available, there was a link between a history of periodontitis and periimplantitis, and smoking in 12 out of 13 studies. So those are basically the three ones that are clearly so far associated to the presence of periimplantitis. And then if you have a case like this with untreated periodontal disease, you put implants in the lower, you wait 4 years, you have continuing disease in the upper. Now almost this one, tooth number 6 here, is more or less lost. But also now if you look at the implants, you will see that you have periimplantitis on all the implants that were placed in this specific patient. So if we do not treat the presence of periodontitis, I think we are running a higher risk for our patients in the future. And for you, I mean, this is now, I think, something we can do, all of us, in our clinic. We can look like this. You know, we know roughly that regardless of where you go in the world, around 10%, it could be 7, it could be 8, but around 10%, say, of adult individuals has advanced periodontal disease, roughly. So this box here is all your patients in your practice. And then you, of course, you do some implant therapy. So this box here represent your implant patients in your practice. And then now we put the 10% of the individuals in your practice with advanced periodontal disease. And I think what we should do is really to think, how many of those patients do I have down there? And I would not be surprised if you have at least half of them there. Because what I don't know in Germany, but I know Sweden quite well. And I know that in Sweden at present, we are replacing a lot of teeth lost due to periodontal disease or extracted due to periodontal disease and replacing them with implants. And if we do so, we put the implants in a susceptible host. And we should be aware of it because it also gives a demand on us as the treater dentist really to have a maintenance program that is made for this type of risk assessment. So if you have like this, that maybe in this group, in your whole practice, you have 1 patient out of 10 with a previous history of periodontal disease, but among your implant patients, you maybe, I don't know, but maybe it's like it's every second one. So your risk profile on your implant patients are much higher than on your on your ordinary patients in your practice. And this should be, considered when we really are planning for, maintenance programs and so forth to avoid the presence of periimplantitis. So I would like you to take this on board, that patients with a history of periodontitis, they are risk patients. And also the second bullet point I think is important if we are going to increase the success rate in our practices. And it's like any periodontal disease should really be resolved before we do any implant therapy. Just before the break, I was telling you that patients with previous periodontal problems are risk patients for developing periimplantitis. And of course you can ask yourself then, if that's so, can we really put implants in advanced perio cases? And I think we can. And I will show you this young lady. She was young when I treated her 20 years back or so. A wonderful Greek lady with what I would consider quite advanced periodontal disease for 43 years of age. She has limited, bone support on several of the teeth in the upper. She has a lot of intraosseous lesions. She has, of course, furcation involvements. grade 2 and 3. And the mobility, as you can understand, just by looking at the radiographs. However, in this kind of patients, I am reluctant to be too fast. I'm a very conservative person. So, and I have over the years learned that I need to get some time to get to know the patient, to also to be able to evaluate the results of therapy. So this lady, due to the limited time, I cannot go through what we did in detail, but she first went to my dental hygienist, of course. And then I have made periodontal surgery in all quadrants. We extracted some, not very, I think 1 or 2 teeth we extracted, but not very many. You will see later on. And then she had periodontal surgery in 4 quadrants. And following that, she ended up like this. And this is now just after healing. We still have a little bit pockets, 1-4 in this region and also in the lower part up here in the 3rd quadrant. But otherwise, we have had, quite nice healing. After this, we took the decision to make implant therapy. So we did put 2 implants in one upper quadrant and 3 in the other one. And now you can see her 20 years down the road. We have 3 implants up here. We have 2 implants there. She still has the old bridge, which you could have, think that it wasn't nice, it doesn't look very good. But she felt that this was part of her. She wanted to keep it. And we did a small bridge in the lower to replace the canine here. But you can see we kept diffurcation involved teeth in the lower. We removed them in the upper. And this is the result 20 years later. So, of course, if we have a patient that is willing to cooperate and we can see that there is a good healing potential, we can very well do implant therapy. But she also goes to regular maintenance program. This is important. I will just highlight another thing, also coming back to the study by Sven Rinke, and just look now what smoking may have, the importance of smoking, because we discussed also before the break that smoking is another risk factor. And please now look at the figures. Now, he had, as I told you before, in this study, periimplantitis only in 11.2% of the cases. And this is mainly, I think, due to that they were in a nice structured maintenance program. But if you look at the figures for smokers, 53%, non-smokers 3%. And this is, as you can see, highly statistically significant, the difference between smokers and non-smokers, indicating clearly that smokers may be a risk factor. The second thing, it shows also, you see, compliance. Non-compliant patient had more periimplantitis, but he were unable to find any association to previous periodontal disease. But I used it to demonstrate the importance of smoking. And I will show you, this is a lady I treated many years back. She came for a referral like this, and she has advanced periimplantitis. She was treated 5 years earlier by extraction in the upper and placement of implants. She has not been ending her smoking habit at all. However, if you just look at, this area, you look and see it doesn't look very much inflamed. There are deep pockets, but there is no real inflammation for the naked eye. Patient has no idea. We remove the superstructure, and I do the surgical procedure, and we remove all implants just by using pliers. There is no osseointegration at all. So it's so easy to. This one was the only one that had some osseointegration in the far, apical part. That one was holding the complete bridge, but it was impossible to treat. So we had to remove everything. She has no alveolar crest at all. She was not even 50 years old when I did this. She hasn't stopped smoking, and there is no possibility to do anything. She has to live with her upper prosthesis. That's her destiny, in a way. So when we conclude, from the literature, what we can say around smokers, we can say that, yes, they should be, based on the available evidence, should be considered as risk patients. In my mind, I think that smoking patients should be offered in the clinic a smoking cessation program to have them stop smoking before we even put the implants in the mouth. This is all to make it more safe for you and for the patient, increase the prognosis. And also, if they cannot stop smoking, and if you have smokers that already have their implants, please call them frequently to your clinic for checkups and for maintenance to avoid problems in the future. Now coming to the third, risk factor that was demonstrated in the review by Lisa Mayfield in 2009, and that was bad oral hygiene. And here are results from a study by Serino and Ström in 2009, when they looked at cases in their practice referred for periimplantitis treatment. They found that 48% of the implants with periimplantitis, they had no accessibility for oral hygiene measures at all. So it was, in other words, impossible for the patient to clean those. Half of the ones they got referred were impossible for the patient to clean. And only when they look at the ones that had accessibility, only 4% had periimplantitis. So, bad oral hygiene for sure is an important factor. And if you look at this patient, how should he be able to clean? It is absolutely impossible. There is no way. And you can also see pus coming up here from underneath the prosthesis. We remove the prosthesis, and it looks like that, not very nice. Then, if we look at the radiographs, you see there are periimplantitis on all implants in the upper. And worst of all, if you look at the clinical slide after removal of the prosthesis, what do you see? You see this is, implants that are where the superstructure is screwed on. On top of that, the dentist did put some cement, just to be sure. So, on top of everything, the cement has been pushed down in the pockets, really favoring the development of periimplantitis. So, these are the cases we see. And here is another case where it is, of course, very difficult here to clean. And it has to be, really, this is the way you have to be able to clean. If you cannot clean it like this, what could you expect other than to develop periimplantitis? So if we try to sum up a little bit around oral hygiene or bad oral hygiene, we can say that it is very vital that the prosthetic superstructure is designed in a way to make it possible for the patient really to clean around the implants. And also for us as dentists to emphasize to the patient the need for good oral hygiene in order to have, a good prognosis for the implants that we place in the patient's mouths. Many discussions has been around the implant and the implant surface. There are very few studies basically that are looking at this in the literature. There are a few, not very many. There were a few studies by Ostrand et al. Demonstrating that the old TPS surface did develop more periimplantitis than other surfaces. And there are also one study by Zetterqvist et al. Showing that there were no difference over 5 years looking at a medium rough surface and a machine surface in the development of periimplantitis. This is from our laboratory where we recently looked at, sorry about this, is wrong. It couldn't be 112. So we have 19 tyoblasts and 22 machine Bronemack implants. We have a follow-up of 13 years, and we defined periimplantitis as bone loss more or equal to 1 millimeter after first year with bleeding on probing or suppuration. And the reason for going down and using 1 millimeter is that we now have a previous radiograph to relate to, and this is now following the recommendation from the last workshop of periodontology in the EFP. So comparing those two implant systems, the tyoblast and the machined, we cannot find any statistical difference between those systems over time. The incidence of periimplantitis between years 1 and 7 is 26% in the tyoblast and 30% in the machined. And between years 7 and 13, you have 7% in tyoblast and 12% in the machine. So we had more in the beginning, but then the patients were on a little bit more regular checkup after that. These are also patients outside our clinic that we are including in this study. When we looked at those and saw the ones that developed periimplantitis, we saw also here that a history of periodontal disease was a risk for future incidence of periimplantitis. Another thing that we found was that patients with systemic diseases, for example, cardiovascular diseases, were more frequently found among the periimplantitis patients than among other ones. And we had some microbial data at year 7, but we were not able to predict any future events using these microbial data. So it seems like anyway that general disease is also a factor, although we have quite limited knowledge and scientific evidence so far regarding that. When it comes now to the surfaces, we can conclude that yes, rough surfaces as such, they are more difficult to clean for the patients, they are, but there are really no good evidence showing that rough surfaces increase the risk for periimplantitis. And this is what we can find today. Another controversial thing is the presence of keratinized gingiva around implants. What are really the implications for that? Are individuals with no keratinized gingiva at higher risk for development of periimplantitis? And there was actually a recent systematic review published in 2013, and they were able to find 7 cross-sectional and 4 longitudinal studies and they made a meta-analysis on that. And basically, I'm just showing you now the conclusions from the study. And they found that, yes, lack of keratinized mucosa around implants are associated with more plaque accumulation, with more tissue inflammation, with more mucosal recession, and with loss of attachment, if this is what they found. But they also found that lack of keratinized gingiva, or mucosa, you should use the word mucosa, around implants were not associated with bleeding on probing, with more pocket depths, or with radiographic bone loss. So, I mean, there are some contradictory things, and I think we still are unsure about really the importance of the presence of keratinized gingiva or mucosa. However, if you look at this, if there is this type of clinical situation, it could lead to recession, as you can see down here. 1 year later, you have a recession around this first implant here. And as I read the present literature, I think we can say that in patients with good oral hygiene, keratinized mucosa is not a prerequisite to maintain health around implants. I think so. But I also acknowledge that in some situation, it could be an advantage to have keratinized mucosa to improve the patient's ability to clean around the implant.